Welcome to Using Palliative Care in Bladder Cancer, a patient insight webinar from the Bladder Cancer Advocacy Network. Before we begin, we'd like to thank Bristol Myers Squibb, the EMD Serono Pfizer Partnership, Ferring Genentech, Janssen Oncology, Merck, and PhotoCure for their support of the Patient Insight webinar series. My name is Stephanie Chisholm, and I'm the Director of Education and Research at Beacon. I'm joined today by Dr. Elizabeth Wulff-Birchfield, otherwise known as Libby. She's an assistant professor in medical oncology and palliative medicine at the University of Kansas Healthcare System. Welcome, Dr. Wulff-Birchfield. Libby.
Thank you so much.
Go ahead.
Pardon?
Go ahead.
I'm so honored to join. It's okay. I'm so pleased to be here with you, and I'm honored to be able to speak to this wonderful group and as part of this fantastic organization, especially about a topic that's so important to me personally and professionally. And so I want to jump right in. Just to give you a little outline, I'd like to start out by talking about some of the basics of palliative care, followed by some of the existing research establishing the value of palliative care for people who have cancer, and then more specifically people with bladder cancer, look at some of the upcoming palliative care research that I think may change the game, and then circle back to how to access palliative care. Then we'll have time for questions.
Super. So I was going to read your bio, but I'm going to go ahead and let you take it away.
All right. And I do not have any disclosures that should concern you. So let's start by talking about palliative care basics. So as many of you may be aware, I would say that the definition of palliative care has probably been less important historically than some of the connotations of palliative care. And while I think that our perception is our reality, and I certainly want to validate the importance of that, but I also think that it would probably be helpful to share some definitions and some of the nuances of palliative care as someone on this side of the stethoscope and who is a participant in this field. And so one of the groups who has been most important to promoting palliative care has been CAPC, which is the Center for Advancing Palliative Care, as you gather in their name. And so when we look, their definition is really the one that I think most people in my field turn to. So the first part of their definition would be that palliative medicine or palliative care, terms that we use interchangeably, is medical care for people who are facing a serious illness. The second part of our definition is that this form of medical care focuses on providing relief from symptoms, but also trying to just make quality of life better and removing barriers to that, whether that be symptoms, distress, caregiver burden, and that's irrespective of the diagnosis that is causing those things to the patient's life and that of his or her caregiver. The goal of palliative care is essentially to make sure that everyone is living their longest, best life, and that means patient and caregiver. And so therefore the third part of the palliative care diagnosis is the goal is to improve quality of life and make it as good as possible. Something that I think is really special about palliative care is the way that it is conducted. And I really believe firmly that all branches of medicine are a team sport. And I think oncology and urology really do exemplify that. But I think palliative care takes it almost to a different level. The reason I say that is because palliative care really relies heavily on an interdisciplinary team, and believe it or not, one in which the doctor does not rule the roost. I think a lot of medicine has historically been structured, probably for worse, around the physician as part of it as a team leader. But in palliative care, we have a very, very flattened hierarchy, and the team is made up of physicians, nurses, as well as social workers, chaplains, whenever possible, child life specialists, whenever possible, and forgive me for leaving advanced practice providers off of this list because they are certainly central to these teams. And then depending on the setting in which a given palliative care team is operating, there may be other specialties involved. And that really depends on the patient population who is being served by that team. So I think if we have a palliative care team embedded in a neurology clinic where patients may have dementia, sometimes a bioethicist may be part of the team in order to really make sure that we're meeting the needs of the patient population and caregiver population we're serving. So the other thing I would emphasize, and that really does often get put in last as part of any palliative care definition, is that palliative care is appropriate for, as we say, any age, any stage. It's really, and it can be provided alongside care that is given with the intent of cure. I would imagine that there are people participating with this who have either been a patient or a caregiver for some incredibly aggressive treatment for any number of medical conditions. And we all have either observed or experienced the burden that comes along with that. Therefore, palliative care is meant to help alleviate some of those burdens, regardless of the intent of treatment. So another set of interesting things about palliative care is that while a lot of specialties flow sort of fluidly from inpatient to outpatient, outpatient palliative care and inpatient palliative care are very different, are sort of almost sub-disciplines of the larger field. And I'll explain what I mean by that. But so palliative care can absolutely be inpatient, outpatient, and sometimes in the home setting, but the makeup of the team is often different, and the intent of the care is a little bit different between the settings. The inpatient palliative care setting is the most common that we have in the United States. So this is, again, interdisciplinary teams that often are a consultative team in the hospital, or sometimes have specialized medical units. So palliative care units where care is provided to people who need us to help with symptoms. But the other thing that's unique about this is that I would consider inpatient palliative care often focuses on sort of crisis management and helping think about, again, what are the goals, what are the barriers, and then figuring out how to transition someone from life inside the hospital to life outside the hospital. Because rarely is it that someone thinks life in the hospital is better than out, and if it is, then that person is probably in trouble with a lot of things going on outside, and so we need to help their life be better. Outpatient palliative care is occurs less frequently, at least at this time. This is rapidly changing, but this is still a little bit of a niche discipline, to be perfectly honest. What I would say is that while many fields, as I said, have this fluid inpatient to outpatient to inpatient to outpatient organic flow, outpatient palliative care often develops because of a champion from within another clinical program. By that, what I mean is that there will be clinicians or sometimes advocates or other staff members who are working within a clinical program such as a cancer center, or perhaps a lung, liver, heart transplant program, or a left ventricular assist device program, a neurology clinic, etc., who sees some of the needs that their patients have and sees that they're lacking for solutions. And so often that is where these programs develop. What I can say is that at the University of Kansas Cancer Center, who has a pretty well integrated palliative care program, if I may say so myself, our program was spawned because one of the bone marrow transplant nurses named Amy Velasquez saw that there were some needs that didn't really have a good solution at KU. And so she is really the person who spawned this program and still is a member of our team to this day. Outpatient palliative care, unlike inpatient palliative care, we hope won't be crisis management, but rather is something more focused on cultivating a long-term relationship with the patient, the medical team, and the caregiver team, whoever that is for each individual patient. Certainly managing barriers, managing symptoms, helping with communication, but also providing anticipatory guidance. Many times people with serious illnesses we can predict that they may have progression of that illness over time or may have clinical deterioration over time. And therefore, we can help predict what the road ahead may look like and make sure that the medical care people are getting and the support that they're getting is a good fit for what matters to them, regardless of where we are on the journey. So a lot of times the elephant in the room when talking about palliative care is hospice. And so I think it can be helpful to compare and contrast palliative care and hospice. And what I would say is that when I describe palliative care and hospice to my patients, I describe hospice as a special form of palliative care, which I think is true. And there are some pretty important differences. So first, when we think about palliative care and hospice, the things they have in common are that patients have, this can be for patients of any age, any stage, of course, but hospice, while that is true theoretically that it could be any age and any technically defined stage, the one criterion that's actually required for hospice referral and participation is that the patient needs to have a life expectancy of 6 months or less predicted by their physicians, by two physicians, if their illness follows its natural course. So some other differences are the setting, and I'm sorry my slides haven't translated perfectly, but what you can see is that palliative care, as I mentioned, that happens in hospitals and outpatient clinics mostly, sometimes at home. But and while palliative care is in hospitals, clinics, and sometimes at home, hospice actually mostly takes place at home. About 85% of hospice at any given time, at least in the U.S., is taking place at patients in their home setting. Now, if they live in a nursing facility, that means that is the home setting for that person. But there are also inpatient hospice facilities, the intent of which, or sometimes called hospice houses, the intent of which is to manage symptoms that can't be controlled in the home setting. Sometimes there are also residential hospice facilities, which are, to be perfectly honest, a really confusing concept for someone, but the way, or for even medical personnel, but the way we usually think about it is some hospice facilities or hospice houses have beds that are for patients who really need nursing home level care, and we'd be paying out of pocket for that regardless, but also qualify for hospice and are choosing to live in that facility. That's pretty nuanced, and not every hospice agency can provide that, and Medicare does not require that hospice agencies are able to provide that level of care. So in terms of the finances, palliative care is just another specialty of medicine. And so just as specialty care for dermatology or cardiology or nephrology would be covered by, on the inpatient side, by Medicare Part A, Medicare Part B for outpatient care, the palliative care has that same payment structure, whereas hospice is very different because it's really an all-inclusive Medicare benefit. And what's interesting and wonderful about that, and sometimes tricky, is that the hospice benefit pays for everything, all medical care, all medications, all supplies, all any lab tests or x-rays or any of those things that are needed to help someone live their best life and that pertain to the symptoms and medical burden related to their primary diagnosis. And so what that means is that any supplies, be it a shower chair, all the way down to your medicines or oxygen, et cetera, is all covered. Generally, commercial payers will follow suit for the same coverage policies, although there unfortunately are commercial payers that don't cover hospice, which is very rare. And then finally, when we think about another important distinction between palliative care and hospice, almost all palliative care is care provided alongside regular medical care, whatever the patient needs for the rest of their health conditions. So again, if someone has cancer, then they're going to be seeing their oncologist, their radiation oncologist, maybe their surgeon, depending on what their needs are. And palliative care does not threaten that. It doesn't undermine it. It doesn't take it away in any form or fashion. It just adds to it. Hospice is different. Hospice is meant to be holistic care, not just based on physical needs, but emotional, psychosocial, and spiritual needs. And so because of that, patients who are enrolled in hospice have to forego life-prolonging treatment that is directed to their primary illness and related to their overall sort of prognosis related to that primary illness and their overall trajectory.